And so my talk today, I'm going to take you through a little flavour of what is asthma. We all feel we might know what asthma is, but we're going to go through exactly what is asthma. And unfortunately, people still die from asthma. And despite many really good therapies, it's estimated in Ireland that perhaps 1 patient per week dies from asthma. So I'm going to go through some of the risk factors that we've had from recent studies on that. And then, again, we've got some new treatments in asthma for patients who don't respond to our standard therapies. And like Professor McAvaney has alluded to, many of these new treatments come with a cost. So asthma is what we consider as lung doctors an airway disease. And our airways start essentially from our nose, and they run right through, down into the lungs. And for patients with asthma, any component of our airways can be affected, but in particular what we consider our smaller airways, so these little branches within the lungs. And for many patients, their nose is often quite significantly affected. And if we look at the actual airways themselves in patients with bad asthma, if this is a normal airway here, you can see in this airway that there's a very thickened wall. There's increased mucus production. The muscle becomes quite thickened, and it constricts in particular during bad worsenings of asthma. And so you get this inflammation and mucus in the airways themselves. And what's perhaps characteristic of patients with asthma is the variability in the symptoms they get. So all of these changes in their airways, they can cause cough, breathlessness, and wheezing. But for patients who've milder asthma, they can have periods of being perfectly well, but during worsenings of their asthma, they can have real significant symptoms and difficulty breathing. And there's also variability during the course of the day in terms of their symptoms. So it's characteristically worse at night, for example. And also for many asthmatics, there might be a trigger that can cause their symptoms to worsen. So a significant proportion of asthmatics are sensitive to things in our environment. And you'd be probably familiar with kind of allergic asthma and things that, like grass and pollen that can trigger their symptoms and cause acute worsenings of their asthma. And so that's very characteristic of asthma. However, not all asthma is the same. And in the medical world, we talk about a phenotype. So you can think of it more simply as your type of asthma, but phenotype is a very specific definition. Asthma is strongly genetically based and often runs in families. And so your phenotype is the interaction between your genetic makeup, so changes in your genes, with your environment, so things you're exposed to in your daily life. And so whether that's that you live in a very polluted city or that you're exposed to animals that you're allergic or sensitive to. And we're more increasingly recognizing other components of our lifestyle can affect our asthma control. And so obesity is being increasingly recognized as a factor in poorly controlled asthma. And so it's the interaction between our genes and our environment that lead to what we call our disease expression. So what the asthma looks like in that individual patient. And so if you have a room of asthma patients, between those patients, they may actually have very different symptoms and very different types of asthma. And there's loads of ways that we can characterize what their asthma, what type of asthma they have. And as doctors, this is important because this can help us to target treatments for these patients. And so I've kind of a little brainstorm of some of the types of asthma. And for some patients, they've overlaps and they've got several subtypes of asthma. And as I said, probably the most common one we'd know of is patients who are allergic and sensitive to pollen, to their cat or their dog, also to house dust mites and molds and things in the atmosphere. Some patients have a tendency to a huge amount of mucus production. So some asthmatics have a dry cough and it's worse when they exercise. Other patients might bring up copious amounts of sputum, almost to the same degree as perhaps the cystic fibrosis patients. And on their CT scans, you'll see very thickened airways. So these little circles here are some of those small airways, and they're really thickened and inflamed. And occasionally these patients go on to develop bronchitis, which is, I suppose, an acquired form of a cystic fibrosis condition. Other patients have quite differences in their physiology. So you can have Olympic athletes who have asthma. They have super lung function. But if they were to inhale an irritant, their lung function can drop significantly. And so they have asthma. But you might have another patient whose lung function, even at their best, is already reduced. But if they were to take their blue inhaler, their salbutamol, their lung function would improve significantly. And then you can have patients who've had asthma for quite some time and have what we call fixed airflow obstruction. So their lung function is permanently reduced from having chronic asthma for many years. And those patients can behave a little bit more like a patient with emphysema or COPD. And then we can look more at the tissue and the cells involved in asthma. So asthma is actually an immune system type disorder. So even though it affects our airways, it's really our immune system has run amok. And these cells here, this is an eosinophil, which is a little white blood cell that has really, our body was designed to fight off parasites with this blood cell. And so one of my colleagues used to call these blood cells the naughty children in asthma, that they'd really gone amok and started to increase in numbers, lots of them in the lungs. And they're responsible in many asthma patients for the inflammation in the lungs. And they're a target for our broad treatments and for some of these newer treatments I'll talk about later on. But when we look at the types of asthma patients, and that's important in the treatments that we choose, as doctors, we're very concerned about whether or not our asthma patients are controlled. And more we're looking at, is your asthma controlled or uncontrolled, or is your asthma severe? And so there's been task force and a lot of focus looking at, well, what's the difference between an uncontrolled asthmatic and a severe asthmatic? And it is important for us because these patients are inherently quite different. And essentially, an uncontrolled patient is a patient who's not on the right amount of therapy for them. Whereas a severe asthmatic patient is on the maximal inhaled steroid treatments, but they need that to stay controlled, or if they were to reduce on that, they come uncontrolled, or that they're on those treatments and they're still uncontrolled. So they're inherently a different type of patient to the uncontrolled asthmatic patient. You could have relatively milder asthma, but just not be fully controlled and need a little bit more therapy. And the importance of this is that they are the rare condition within asthma. So the severe asthmatics truly are rare, and they're probably at best 5% of all asthma. But they account for about 50% of all of the healthcare costs associated with asthma. So these patients are more likely to be in hospital, they're more likely to have side effects from all the drugs that we're using to control their asthma, in particular steroids, which are quite an effective drug but full of side effects. And they're also potentially going to need some of these newer treatments that are very expensive. But are these the patients who are dying from asthma? So is it the severe asthmatics who are ending up accounting for the one death per week in Ireland? So there's a very good study published about 2 years ago in the UK, and it's probably one of the better studies looking at asthma deaths. There's been a lot of studies over time. And what they did was, over a 1 year period, they looked at all death certificates that had included asthma as a contributor towards that patient's death. And they studied each of these cases and determined definitively in 195 of over these 3,000 cases that 195 people had definitely died from asthma. So there may have been other people in that 3,000 who died from asthma, but when they looked at the notes, they could confirm these 195 people, definitely asthma was the direct cause of death. And then they looked in detail at those cases to see, could we learn from these cases why these patients had died in an era where we have really effective therapies for asthma. And perhaps one of the most sobering factors I thought from the published findings was that nearly half of these patients had not received emergency care in their final asthma exacerbation. So they died without having received medical care. So many of them would have died in their homes or on their way to seeking emergency care. And so I suppose the missed opportunity was predating that final asthma exacerbation. Many patients weren't under a specialist, and many hadn't seen their GP in the last year. And particularly of concern was that the younger patients, so those patients aged between birth and 19 years of age, those patients, there seemed to be a disconnect both with the patients and the healthcare professionals in recognising that they were at risk of death from asthma. And it seems that on both sides, when they looked at the data, both the doctors and the patients didn't realise that their asthma was either very poorly controlled, or that their behaviours or their care was putting them at increased risk. And 93% of them didn't meet what we would consider basic chronic disease management. The simple things like, can they use their inhaler? Are they picking up their inhalers? Are they taking their inhalers? Just simple things. And when they looked at the inhaler pickup rate, in general, these patients were picking up lots of their blue reliever inhaler, which doesn't treat their asthma, but not picking up enough of their steroid inhaler. So the learning points from it reiterated many established risks. So we know if you smoke and you have asthma, that is a really bad idea, and it puts you at increased risk of death. So a fifth of these patients smoked. And if you looked at all asthma patients, it's a disease that occurs in never smokers. And so this is a disproportionate number of patients who smoked. We know that if you've got poor social circumstances and psychological or psychiatric conditions contributing, that can make that challenging for patients to get the care they need. We know if you're uncontrolled, being hospitalized for your asthma, again, that will increase your risk of sudden death from asthma. 48% of patients weren't taking their medications or sufficient amounts of their medications, and a third were obese. But there were several findings that hadn't been previously reported. As I stated at this sobering statistic, where many patients aren't actually getting to hospital or to a healthcare professional. Most of these patients had adult onset asthma, so we often think of asthma as a condition of children, but you can get it at any age. And 70% almost of this cohort, their asthma had started as an adult. So is that a different type of asthma? And it really likely is. Many of them, they died during the day, so really again, why didn't they get that help they needed? And the variation we know that can be a pattern for asthma in terms of seasonal worsenings of asthma. The deaths in terms of seasonality really were only seen in the younger patients. So it was a cluster of deaths both in spring and in autumn in the younger patients. But the adult patients, there was no pattern in terms of the time of year when they died. So of course that's all a little depressing. So we're going to get on to something maybe a little more upbeat. So there's some really good new treatments for patients with what we call severe asthma, where our basic drugs, which actually really are excellent, so inhaled steroids have revolutionized asthma. And it used to be the case before my time that there'd be lots of asthmatics coming into the A&E acutely unwell before we had inhaled steroids. Inhaled steroids are a phenomenal drug. But for some patients with asthma, they're not enough. They're not enough to control these patients. And so we've got some nice new treatments that are unfortunately very expensive that can help control patients with severe asthma. And I'm going to go through a couple of cases just to give you a flavour of what some of these severe asthma patients, what the symptoms they have and some characteristics, and go through briefly some of these new treatments. So when a patient is referred to my specialist clinic with possible severe asthma, we take a very systematic approach. So the first and most important thing to determine is, does this patient have asthma? The symptoms, like I described, cough, shortness of breath, wheeze, they can be features of many lung diseases. So the first effort is to confirm they've had asthma diagnosis, which can actually be a little bit more challenging than you might realise was important. And then what I often find is that many patients have what I call asthma plus. So they've got asthma plus something else. And so some of these conditions here are rare diseases, but that we see more commonly in patients who've had asthma for some time. And that can often be why it's more difficult to control their asthma with these basic asthma medications, because most of these illnesses, they don't respond to inhaled steroids. And so we then need to address these additional conditions they may have. And this picture on the right is a nice example of a patient who did have asthma, a young lady, who came to see me, and she'd had, for the last couple of years, suddenly been getting all of these chest infections. Her symptoms were worse at night, which might suggest it was her asthma, but it seemed different to her usual mild asthma. And so as part of her workup, we did a CT scan of her chest. Now, somewhat embarrassingly, she should have had a chest x-ray, but we went straight to the fancy CT scan. And we would have seen this actually on her chest x-ray as well. So these are her lungs here in black, and this big tennis ball in the middle is her esophagus or her food pipe. Usually that's a tiny little slit that we barely even think about when we're looking at the lungs. And you can see here she's this massively dilated esophagus, and it's full of food. So what should be in her stomach is sitting in the middle of her chest. And so when she lies down, that aspirates up, sprinkles down onto her voice box, into her lungs, and is causing both irritation and infection. She had this surgically corrected, and I saw her a month after her surgery, and she was like a new woman. Now, I had to remind her to take her inhaler because she still had asthma, but she had a totally different cause for her uncontrolled or severe asthma. However, many of the patients that we do work up ultimately have uncontrolled or severe asthma. And this is another memorable case that I had just last year. So there's a young lady who was referred to me from the allergy service because her asthma was poorly controlled. And when she came into the clinic, there were two things that I noticed about her. Firstly, she was notably overweight. And actually, when we did her lung function test, they checked your height and your weight, and they calculated her body mass index. And I hadn't even realized, but it came out at 50. So even looking at her, I hadn't realized that she was morbidly obese. So your BMI should be between 20 to 25, and this here is really what we call in the morbidly obese range. So that in itself is a challenge with asthma and will not help your breathing. She also, the moment she started to talk, had obvious nasal obstruction. And when we did a CT scan of her sinuses, and unfortunately this is not her scan, but it's a representative scan, she had complete blockage of all of her sinuses. So this here is air. So on her scan, she had tissue like this, but throughout. And so she had no air running through her nose. So she had extensive nasal disease with polyps and obstruction. What was a little less obvious with this lady, and there was the nurse actually sitting in with me commented on it afterwards. So she was wearing rabbit earrings, and she had a handbag that had all these little rabbits on it. And she had rabbits at home. And she's rabbit allergic. So this is definitely a problem for this young lady, and she loves her rabbits, and of course one of our first things to discuss is whether or not she would remove the rabbits. So I have a puppy, I love my puppy. If I was allergic to him, I think it would be heartbreaking to get rid of him. And so it's a difficult conversation to have with patients who are allergic to their pets. And what I find is most of the time people really refuse to find a new home for their pets. And so you have to counsel them to say, well, look, when your pet dies, please don't get another one. And it really takes over a year for the proteins that are on animals' fur to completely go from your home. So it's not even a quick fix if you were to rehome your animals. This young lady also, when we looked into her records a bit further, she didn't realize the importance of her inhaled steroid. So she wasn't taking her inhaler. She'd only picked up 3 in the last 12 months rather than the 1 a month that she needed. As mentioned, her weight is a significant issue, and we know when patients get to that degree of obesity that really bariatric surgery should be considered early, and that the usual weight reduction measures don't work. And there's a nice study recently showing in patients who were morbidly obese with asthma, who underwent bariatric surgery, they had significant improvements, not just in terms of weight reduction helping your lung function, but their actual signs of asthma inflammation reduced. And so we think that there is an inflammation driven by fat. So it's something a little more complex just than the physical weight itself. ENT, or the ear, nose, throat surgeons, could debulk her disease and help control some of the nasal symptoms. And then if these options don't work for this lady, we have a new treatment that's relatively new over the last maybe 10 years. That's an anti-allergy treatment, and it's a very specific treatment that binds onto what we call IgE, which is an immunoglobulin, and it's part of our immune response to allergy. And so it binds onto that directly and essentially stops it from working and stops it from being involved in the allergic process. And it's only suitable for people who have the allergic type of asthma. We don't give it to people who have allergy just driven by things that can be removed. So if you're allergic to cats, or if you're only allergic during the summer months, it's not really for that scenario. It's for people who are allergic to things that we can't get rid of. So we can't get rid of house dust mite, even though we can try control them. And some patients are allergic to mold, which again we can't get rid of from our environment. The guidelines in the UK are quite strict. It's an expensive drug. It can cost up to $30,000 a year. Once you go on it, you're likely to remain on it long term. So it is a big undertaking, and so the NHS has quite strict restrictions. You have to have reduced lung function, be requiring a lot of steroids, they say 4 in the last year, and it has to be to these perennial allergens, and of course you have to have asthma. For this young lady, you wouldn't like her to be at the point of needing 4 courses of steroids necessarily because of her weight issues, and so sometimes the guidelines for us as physicians, they're restrictive, and they don't always go along with what we might feel is appropriate for individual patients. But we do know that this drug works fantastically well. It's interesting. You have 2 patients who have exactly the same blood tests of allergy, give them both the drug. One could dramatically respond and the other may not. So we still don't know per patient who will respond. But we've definitely had patients where they feel like their asthma is completely fixed. And when you look at the groups overall, they do very well in terms of reducing down their steroid doses. This is some Irish data here published by my colleague Richard Costello. And you can see that they've had significantly fewer worsenings of their asthma, fewer hospitalizations, and the number of days they'd be in hospital significantly reduced. I like this data, which is from a pediatric population, and these are patients who received the drug, which is omalizumab. compared to placebo. And you can see nicely here the peaks in their worsenings, both in the spring and in the autumn. And when the patients got omalizumab, they had less worsening of their asthma and the smoothing out of those worsenings, so there was less of a variation. And that would be consistent to it working during their months when they're maybe most allergic. The second case is a case of a patient who doesn't have allergic asthma but has severe asthma. And she was an older lady that I've just recently met in clinic. And she had asthma as a child, and she also significantly had a bad respiratory tract infection when she was young. So her lungs continued to develop up until about the age of 2. And there's some evidence on her CT scan that's very subtle, but there's some evidence that her lungs were permanently damaged, perhaps during that episode in early childhood. She'd outgrown her childhood asthma. In her 40s, she had a little bit of nasal disease. And then recently in her 50s, for whatever reason, her asthma returned and with a vengeance. She's no triggers, she's not allergic, she's never smoked, but she has a strong family history of asthma. And steroids work fantastically well for her. When she gets steroids, her symptoms dramatically improve, but once she comes off them, her symptoms deteriorate. And when I saw her, she was actually on a daily dose of steroid tablet. This is her bronchoscopy, so the camera test Professor McElvaney talked about. This is her main airway here. She happens to have a couple of little nodules on her trachea, which are really not causing her any problems. And the name for that condition is like a mouthful, so I'm not even going to say it, but it's a benign condition. And then she's all this mucus in her airways. And when we looked at that mucus under a microscope, it had lots of those cells I talked to you a bit about earlier, those eosinophils. And so she has what we call eosinophilic asthma, but not allergic asthma. And these are the levels of those eosinophils in her blood. So this was before steroids, very high. After steroids, went down to almost undetectable and within the normal range. So this here is the normal range. But then the moment she comes off steroids, they rise right back up, and with that, her symptoms deteriorate. These are her lung function tests, and I saw her around here. And so she'd been referred to our specialist service with what they called fixed airflow obstruction. It seemed reasonable. She's had terribly low lung function, 42, and dropping down further over the last 18 months. And so it seemed reasonable to say that this lady had fixed airflow obstruction. That wouldn't reverse with treatment. And this is her flow volume loop, looking at that FEV1 we talked about. And when I saw her, she was in real trouble. She'd got down to 28%. 60-year-old lady, otherwise well, and absolutely miserable, breathless, doing anything. And so one of the things that I know from treating severe asthmatics is often steroids, when patients say steroids work and when they've got lots of those eosinophils, it's worth trying to see with a higher dose of steroid for a longer period of time, can you get their lung function better? And so I gave this lady 8 tablets a day for a month and brought her back with a repeat lung function. And you'd almost think that this lung function is from a different patient. And she had her FEV1 at 68%. So she'd had a dramatic increase of over a litre in her FEV1, and she felt fantastic. But unfortunately, she's on 8 tablets of steroid a day, and she already has osteoporosis from her previous steroid exposure. So this is not a sustainable long-term solution for this lady. There are some medications we can use when patients end up dependent on steroids, and they're immune suppressant medications, but they're full of side effects, and personally, I hate them. I think that the balance of those side effects for the gains you might get in terms of reducing steroids, I don't think they're worth it. And when they've looked at them in studies, that's generally been the consensus as well. But occasionally, when our back is against the wall, we will try these treatments to try and get down the steroid dose. But thankfully, we have some newer agents that are coming available that don't have all of those nasty side effects and that seem to be helping these patients to get off their steroids and reduce their exacerbations. And these are what we call some of these new biologic therapies that are just recently coming to be licensed both in the States and here. And then there's another treatment that may be an option for this lady also, that I'm going to just discuss first over the next couple of slides, and then we'll go back to these other biologic therapies. So rather strangely, there's a treatment for asthma that involves burning your airways. And you can imagine that doesn't sound like a good idea. But a group, I suppose, who were thinking outside the box knew that in asthma we get this bulky thickening of our muscle. And we know from other conditions that if you heat muscle, that you can reduce its bulkiness. And so they developed this treatment where you put a catheter down into the airway during bronchoscopy and apply heat to the airways. So I'm going to show you a little video of this. So this is us down in the airways. And we've passed down a little catheter, and it has at the end of it almost like a little umbrella. It's dilated, and then you press a pedal, and you hear this beep sound, which is the heat being applied. So it's 65 degrees Celsius for 10 seconds. You apply it to that segment of the airway, then you close your balloon, pull it back a little, and apply another component of heat treatment. And you do this systematically to each airway, and it's done over 3 procedures. So you just do one section of the lung per procedure, and the procedures are spaced out a month apart. That treatment is not for everybody, and in particular, if your lung function is already reduced, if you're producing a lot of mucus, it may not be the best treatment for you. It can be associated with worsening temporarily of your asthma initially before potential improvement. So I would very much reserve that for patients who've tried everything and who don't have a loss of mucus and reduced lung function. So for that lady we discussed earlier, even though her lung function has improved, it's not something that I'm considering for her at the moment. However, these newer biologic drugs, definitely something that I'd like to offer her in the near future. So our immune system has these little molecules called cytokines in them, and they're responsible for coordinating and signaling other cells to do things. And so there's a few ones that are involved in the little eosinophil cells that I've been talking about, and one of them is Interleukin 5. And so there's a new drug now available in the US and the UK, not yet available in Ireland, that binds onto and inactivates this interleukin 5. And what it does is it reduces the amount of eosinophils produced by our bone marrow. It reduces the survival of these cells and how toxic they are. Another group of cytokines bind onto another cytokine receptor, and these molecules are involved in lots of the different areas that cause inflammation in asthma. And again, there's some promising studies of drugs binding onto this receptor. They're still in the clinical trial phases, but I would be optimistic that in coming years that these will be available to patients also. As Professor McIlvany alluded to, unfortunately, it takes a lot of development to develop these drugs. They're quite clean drugs compared to steroids because they're very specific, whereas steroids are a little bit like a sledgehammer, and they're very expensive. And I suppose we're hoping that they'll be available in Ireland, but as we've seen with Orkambi, not all drugs will get approval to be free for us to prescribe in Ireland. And unfortunately, these drugs don't work for patients with asthma who aren't allergic and who don't have those eosinophils. And so there's ongoing work for those types of asthma patients. So lots still to do. So I hope you've got a flavour for what asthma is and some idea of who might be at risk for death, and a little flavour of the novel treatments.